Good morning, good afternoon, good evening, everyone, depending on where you're logging in from. My name is Swabra Swaleh. I am a gynecologist based in Mombasa, and I am privileged to talk about female vitality and, to be more specific, female sexual dysfunction. This is a long, drawn out topic, usually forgotten, swept under the rug, and we know it's an issue. It's an issue. I know last time we talked about male sexual dysfunction, and it is only right that we wrap up the session with a female version. Those are my credentials, and without wasting much time, I will jump straight into the slideshow. If I'm audible, if we are together, kindly give me a 1 in the chat box as well. Give me a 1 and kindly post your questions as we go. I will be addressing them probably as we go or probably at the end. Good, so let me take this out. I don't know how to take this out. Oh, perfect. So when you're talking about sexual dysfunction in the females, these are any sexual complaints or problems that are resulting from disorders of desire, arousal or orgasms, or pain that could result from sexual intercourse. And so vitality by itself as a word refers to the ability to live, to grow, to develop, to thrive, having energy, being active, okay? And if I'm going to talk about female sexual dysfunctions, then it is only fair that I start from a common ground that is common to all females. And these are the normal transition as we go through the phases in our life. So there is adolescent and there is reproductive age. And then there's a woman going through pre-menopause, menopause, and post-menopause, all those three called the perimenopause. And so I'd quickly refer all of us to this diagram and how menopause sort of affects the woman and how it is actually a daily thing that we live with without even realizing that we're living with. As long as you're a woman, 35 years and above, you're definitely started on a journey of sorts. And usually that journey starts from a receding or a pulling back of your female reproductive hormones, and sometimes not just the female reproductive hormones, but basically a reduction generally in the hormone synthesis. So we might also have some other hormones that are not necessarily of a female reproductive age or female reproductive sector also being pulled back. And to be specific, testosterone, okay? So how then do you present if you are a woman in perimenopause? So estrogen goes down. What does estrogen do? I usually start with the very big ones, very big ones, because every time we talk about perimenopause, we usually quickly jump into a woman, having hot flashes, a woman who's moody, a woman who's, no. The very big ones here are your heart and your bones. So what happens? Usually estrogen helps to drive calcium in your bones and also helps to drive vitamin D in your bones. So basically when estrogen pulls back, we do not have that physiological process happening. So that means we're left with bones that are a bit brittle, a bit, less in calcium. You also have to imagine, assuming that this woman has had a very active reproductive age, that means she's carried babies. During pregnancies, you've literally given of your calcium to the baby or you're carrying. And during breastfeeding, you've literally given of your calcium to the baby you're carrying. And that is one baby that is potentially taking calcium and all these beautiful supplements or nutrients from you for like 3 years, assuming you're breastfeeding for 2 years. Multiply that by the number of babies you're eventually going to have. And that should put into perspective how much of our nutrients as women we naturally lose, even as we go through the normal processes. And then on board the perimenopause age where even the body now turns against you and is not able to recover or recoup. So we find that there's a very big gap. Number two is usually the heart health. And I know it doesn't sound like perimenopause and the heart are connected, but they're actually very much connected. Fun fact, we have more knee replacement, hip replacements done on women compared to men of the same age, that is 50 years and above. When you're talking about heart health, if I was to compare a 25-year-old female and a 25-year-old male at the height of their reproductive age, the male will definitely have a higher risk of a heart attack compared to the female. Why? The female has a very high level of estrogen, and this is quite protective because what it does is it takes the bad cholesterol and turns it into the good cholesterol. What happens when we have estrogen pulling back? We have a buildup of a bad cholesterol, and then we have atherosclerosis, all those bad conditions that clog up your arteries, and eventually you do have this woman carrying an inherent risk of a heart attack that is three times, not even twice anymore, three times that of a same man the minute they hit 45 years and above. So the tables do actually turn, and those are the very big ones. The heart attacks that we see, this estrogen allows your body to synthesize melatonin. Melatonin gives you that clarity of mind. Melatonin gives you that, sharpness and focus. And so you realize you're just not focused. Like you're constantly in a gray zone. You're not quite sure. Did I? The stories are you're definitely locking the door twice. Did I lock? Did I switch off the iron box? You just do not have good enough memory. You're wondering what is happening. The same melatonin also gives you good sleep hygiene. And so what happens when you do not have enough melatonin, when you're going through your perimenopause? So that means these women usually are plagued with a lot of what? Insomnia. You will ask me, someone who's not sleeping properly, you recommended 7 to 8 hours in a day. Proper rest for you to rest your slowing metabolism controls a lot of things. We're talking about hot flashes. I'm taking it, by the way. Usually I say it's just the dysregulation of temperature. When it gets hot, you get really hot. When it gets cold, you get really cold, because estrogen acts as a thermostat to the woman's body. And a thermostat is like the way a sea, it's on auto. So it regulates. When it gets hot, it sort of picks up. When it gets cold, it sort of decreases. So you lose that. When it gets hot, you're burning. And when it's cold, you're actually freezing. Bone loss, we already talked about that. Dry skin, already talked about that. Weight gain is a big one here. As we said, every year you lose 1% of your muscle mass. And when you lose muscle mass, what happens? The body does not recognize vacuums. And so what would happen is where the muscle has been lost, then it is replaced by fat. And that's why the common statement usually is, I may, Swabra, there's a way I'm exercising the same, but I'm just gaining weight. It's not moving. It's not, no matter what I do, no matter what usually I say it's simply because you're lacking muscle. So the agenda should be to gain muscle. Then, of course, there's a discussion of a day, which is a sexual dysfunction. And the sexual dysfunction here is a whole lot of array. We are starting from arousal. We're starting from hypoactive function of hormones. We are going to the actual appearance of your female reproductive organs. How do they actually look like when we have the hormones pulling back, and how does that affect your sexuality as a woman? We have a thinning of a labia, and that is both labia majora, labia minora. We have the shrinking of the clitoris, and the clitoris sort of pulls back. The skin down there becomes a bit thinner, more friable, so you realize you're getting more bruises with just the normal sexual encounter you used to have, okay? I like that this topic was given to me. I'm a gyna, and so today there is no shyness and there's no hiding words into other hidden words. We are saying it as is, okay? Good. I hope we are together. And so then we can't start this topic without going to the actual anatomy. And I usually say, for those that don't know, the female anatomy is exactly like the male anatomy. I love the female anatomy in the sense that it looks very innocent. It looks very small. Like, for example, if you would imagine that the clitoris looked like a tiny little thing, the clitoris is a mighty, mighty, mighty organ, my friend. It can actually surpass the male shaft and the male reproductive organ. And so what is the function of a clitoris when you're talking about female sexual dysfunction? It is the erectile organ similar to the men. And so it does not erect, it engorges. And that is the only difference that we have. And if I was to put them side by side, you can see how the clitoris looks like, and you can see how the penis looks like. Exactly the same. We have a joke in gynecology. We are all born female until some of us decide to be silly and become male. It's not a joke because actually, literally, when we're forming embryologically, our sexual organs, they initially look like the female until some things grow longer, drop lower, and then they define themselves as male. So you can see where the shaft of a man would be. That you can also see that the woman has an equivalent. The only difference is yours is hidden inside. It is not exposed as a man. You can see what eventually will go and form the scrotum in the man. You also have, those are the vestigial organs, okay? So basically, we have what we see at the top, from the clitoris to the clitoral wood, is just a tip of the iceberg, but there is a mighty, mighty organ behind there, okay? The vestibular bulbs are the yellow things you see that are separated right there. And they are paired 3-centimeter structures along the vaginal orifice. Oh my God, stima imepotea. I don't know if I'm audible. Emmanuel, you may have to confirm to me that I'm actually audible enough.
Yes, you are. Proceed.
Perfect, all right. And so what is the function of a vestibular bulbs? Okay, these are usually the equivalent of what we call the corpus spongiosum. You remember the structure of a penis that fills up with blood, remains turgid for the penis to be erect. The same happens with the women. So that is your equivalent of a corpus spongiosum. So they become mighty, they engorge with blood, and actually it's just because probably a black woman may not notice it. But if you are a Caucasian and your skin is much fairer, usually that area looks quite red and pinkish around the time when a woman is thoroughly aroused. It's composed of smooth muscle, and this now forms the erection complex. And of course, it has its own blood supply, which I will not enter deep. Why is Dr. Swabra talking about the uterus when I'm talking about female sexual dysfunction? Because it has a role. If you are abreast with news, especially in the scene of, like the obstetric scene right now. I know last week there was a document that was circulating. There is a big lawsuit happening, and it is in the courts. And it is a certain doctor, and it is a certain hospital. When she had her uterus removed, what you call a hysterectomy, she did not give permission for the cervix to be removed, and yet the cervix was removed. And what about? And obstetric world, gynecology world was, what is the actual value of a cervix? That a cervix was removed and there's a lawsuit for 150 million. Are you telling me that this cervix is actually 150 million in value? But there is a role of a uterus and the cervix in sexual arousal. The cervix is what secretes mucus, what causes your lubrication. And the uterus is what causes the mighty contraction. A woman who has had a good orgasm will tell you, she actually has cramps as she's had the orgasm. So there is a role of all these things. When you're talking about the uterus, we're also going to address the fact that certain procedures may interrupt the innervation. Innervation, you're talking about the nerves here. And so if the nerves that are supplying all these, the labia and all these things, if they are tampered with during surgeries like myomectomy, surgeries like hysterectomy, what you may have is a chronic pelvic pain that may last for a while, and this may compromise the sexual life of the uterus up, so that the uterus doesn't sort of prolapse. A woman who has had, or a woman who has pelvic prolapse will tell you for a fact that sexual intercourse is quite painful, simply because things are sagging lower, things are not supposed to be where they are supposed to be, okay? And here is where I dare come out with chest and say, the same women will probably, not say it, but you know what, let me just leave it for later. I realize my audience is not gynecologist, but fine. There is a role of things being intact, being held up by the sacral ligaments, and just basically being in the proper position, okay? And so here, whenever you're going for surgery, especially pelvic surgeries, you have to have this conversation. What is the role of nerve sparing procedure so that the doctor doesn't chanja everything and take out everything, okay? Good. The pelvic floor muscles, and here we're talking about the levator ani. They are very big muscles that form what you call your pelvic floor, and these are what will give you the spasms. And the spasms are good, especially when a woman is having an orgasm, but sometimes extensive or excessive spasms are what will give you now the painful disorders when you're talking about female sexual disorders. So someone should not tell you that, hey, you know, I'm having painful sex, and the first thing you're thinking is, can I give her something? No, because sometimes it may just be a pain issue, which could actually be because the muscles are spasming. Okay, it's like a muscle pull. Imagine having a muscle pull down there every time penetration is happening. Okay, and so this may give issues, for example, incontinence, anorgasmia, and vaginal hypoanesthesia, meaning the sensation is well reduced, especially if now things are lax. And so when you're talking about these disorders, we're going to categorize them into 5 major categories: those that are hypoactive, sexual aversion, orgasmic, sexual pain, and other sexual pain disorders. And that is according to AFUD classification. This is a classification body and protocol that we use, okay? Now, when we're talking about hypoactive sexual desire disorders, we're talking about a woman who is or thoughts or desire. It is not absent, and I would like to specifically highlight this. There is a thing, there's something called asexual. What is asexual? A woman who is just, does not have any feeling at all. So when you're talking about asexual, that is very different from someone who's chosen abstinence. Asexual is someone who, whether they look at a male or a female, they are not thinking sex, they are not thinking sexuality, they're just averse to that. And that is an actual diagnosis, and that is an actual label. But here we're talking about, what is it called? Where am I? Where's my slide? Sorry. Good. Here we're talking about reduced, okay? Thoughts or reduced desire. So this is usually, most of the time, as a result of endocrine disorders or surgical or medical menopause, where surgical menopause will mean that if I was doing a procedure on you taking out your uterus, that I also take out your ovaries. So that means I take out the source of your hormones. Medical menopause will mean that if you were on some drugs that would suppress the endogenous production of estrogen, okay? I like this diagram a lot, and if I can bring your attention, if we're talking about endocrine being hormones, and these are the things that now are talking about arousal, you'll see that on my left, we have those that turn on or excite, or the hot hormones. So estrogen is good for us, my friends. Progesterone is very good for us, my friends. Testosterone is absolutely, actually testosterone to a woman is a libido marker. Okay, and of course now other things play into it. So for example, oxytocin usually will be what will be causing the contractions of the genital organs. Okay, melanocortin and dopamine and norepinephrine. So those are your on hormones. Now we have those that are your off hormones. So prolactin, for example, and some opioids, if you're ingesting some drugs, but prolactin, I'll use it as an example. A woman who's breastfeeding, God is a very miraculous, he's a miraculous God, because by the time a woman is breastfeeding, that means she's caring for a young. And that means all the rules of nature dictate that there should be no other young, so that she can give her best and her attention, her resources to this young to ensure survival. And so that means when you're breastfeeding, prolactin is at an all-time high. And prolactin, let me tell you, a woman who's breastfeeding, she'll tell you for free. Ananyonyesha yani nakwambia dry as a cassava. Okay, does not have any sensation. Yani hata ukimshika ni kama umeshika yani wet cotton. Okay, does not have any desire. If at all your wife is in this meeting and you're here and she's even trying to give you some, she loves you, because prolactin, the way it's built, it's supposed to keep, okay, the sensations away, guard that woman from getting another pregnancy. It's as simple as that. So you can see that balance, and that balance at any one point, every woman has all these hormones. It just depends which one is excess, which one is dominant, at which season of her life is this thing dominating, okay? But if you go to the diagram underneath, you'll see that sexuality is a function of desire, subjective excitement, and then finally an orgasm, okay? And so we have, so where you see a plus, those are your orgasm or pro sensation. So basically, we're talking about prolactin reducing, we're talking about oxytocin increasing, and how all these hormones eventually interplay with each other, okay? And they will definitely, some induce others to increase, others decrease others, and just basically it's an interplay. And maybe the emphasis on this slide is just to maybe state that at any given point, any woman has all these hormones. Any man has all these hormones. But the question is, what is dominating? What is going on at that point? And so depending on what is dominant, what you're taking, what you're ingesting, what you're eating as your diet, what you're taking as a drugs, what procedures are happening, what life is happening from the outside. So the influences then through these hormones that you see will determine how you express your sexuality. So there's a sexual aversion disorder. To be averse is to reject, okay? This is persistent or recurrent phobic aversion to and avoidance of sexual contact. This sana usually occurs when someone has had childhood trauma, and this could be physical or sexual. So this is PTSD in action. You are touched and you're replaying all the images of what may have happened when probably you are traumatized. And this, by the way, unless it's sorted out and unless we go through a stepwise approach to managing it, sometimes may last a whole lifetime, okay? Good, and that is re-traumatization over and over again, okay? Good. Sexual arousal disorders would mean that there is a persistent or recurrent inability to attain or maintain sufficient sexual excitement. So the woman is very willing to start, but she's not able to sustain that arousal in the middle and a switch off, okay? And so most of the time, the differential diagnosis, what will be the probable causes of such conditions, medical causes, prior pelvic trauma, pelvic surgery, medication, meaning, you know, you are turned on and yes, you started, but in the middle of it, this thing that you're feeling down there, maybe you had an operation down there, it's causing you pain, and you're saying, no, in the middle you switch off, because remember, a woman's biggest sexual organ is not the actual sexual organ, it's actually her mind, where all these hormones are produced. Then by all means, we've dropped the ball, we've lost the plot, okay? Good. And so how does it manifest? This is very common, that a woman may have been lubricated as she started, but in the middle, because does not have enough sexual desire to continue the process. Orgasmic disorder is where now she's not reaching the peak of her sexual excitement. So this causes a lot of personal distress, and it can be primary in the sense that a woman has never attained orgasm, and it can be secondary. And I'd like to spend a little more seconds here. Primary, you may have to tease out a few other things, for example, trauma. And we have communities in Kenya that to this day still have what we call FGM, female genital mutilation. And there's some that do what we call type 4 FGM. What does that mean? Like the whole clitoris, the hood, the labia are all cut off and everything stitched back, such that the clitoris, which is in sensation where all the nerves are, concentrated, is missing. And so by default, you find that she's not able to reach orgasm. Yes, she feels a pleasure of penetration, but because there are other sensations along the vaginal canal, but she does not achieve orgasm as is brought by the clitoris. Secondary would mean, yes, she has had orgasms before, but now she's not able to. And this can be because maybe she's in her menopause, hormone deficiency, surgery, etc. Okay, sexual pain disorders is actually the commonest of all disorders. Is where we have recurrent or persistent genital pain with sexual intercourse. Fun fact, I'll be telling you stories as we go along. I have had 2 patients who came to birth. I've taken them through the pregnancy journey, and they were actual virgins. Aki, don't even ask me how. Actual virgin, meaning by virgin I mean physically they have a hymen. That means there's no penetration that has ever happened, and yet is fully pregnant, and then you wonder how zilimwagwa kwa mlango tu penetration. And so that means that woman has never been penetrated. Somehow sperm sort of flowed in just by depositing at the entrance, and somehow she got pregnant. And so here we were
Doc, sorry, Doc, we've lost your screen.
So now, pain disorders where there's thinning of the skin, and this happened. Can you hear me? Can you hear me?
Yeah, you're breaking at some point, but you're now back.
Okay, now I'm back. Okay, fine. I'll try to move closer. So, when we're talking about the pain disorders, usually I would say, I think I've umenitwagia kidogo. Let me see if I can do my screen again. Yeah. Okay. So, vaginal infections, especially candidiasis, you would imagine that you have a discharge. Isn't that supposed to be lubrication? No, it is not. Actually, someone with candidiasis, the yeast infection down there, it affects lubrication. A woman who has that infection will tell you, and so then having sex during that time is painful. Vaginismus is where there is an involuntary spasm of a musculature of the outer, see it in practice. Like the minute it's like a brick wall sensation. The minute he tries to penetrate, it's like a wall has come up. Like the muscles just close up. And it's not the woman closing legs, it's just the close up.
Hi, Lida.
And so usually penetration will almost always approach. Yeah?
Your network is
Can you hear
unstable.
me? I don't know what I will do. Let me just try. Can I be heard now?
Yes, you can be heard, but at some point it keeps breaking.
I don't know what I will do. Let me see. I'll try move as fast as I possibly can. And vaginismus is where, yeah, it actually tells me my internet is unstable. Vaginismus is where the muscles actually just tighten and you cannot penetrate that woman. So you also have to understand that there are such women amongst us, okay? Other sexual pain disorders, if for example you have down there like herpes is an actual sore, a very painful sore, and sometimes you may not even know it, but it is quite painful. Endometriosis, cervical level, at the rectal level is quite painful, okay? Cystitis, which is an infection of the bladder, and then of course prior genital mutilation and all those other conditions listed there. So the causes here, as we've seen, just to summarize, are vasculogenic, those that come from blood supply, neurogenic, that are neurogenic, meaning nerve supply, your hormones either being depleted or deficient, musculogenic, meaning muscular in nature, things are tightening, and psychogenic, the biggest of all those causes, meaning it's a psychology of a woman in that she is switched off here, okay? Good. So when you're talking about vasculogenic, the risk factors, anything that affects your blood system, hypertension, hypercholesterolemia, smoking, heart disease, anything that touches on your blood vessels would affect, okay, your ability to raise an erection, because remember, these organs have to be engorged with blood for them to erect, for the sensation to be felt, okay? Now, in men, again, we saw last time that if at all your blood vessels are not pumping enough blood, we're talking about erectile dysfunction and all these other conditions, okay? And so in the woman, we have diminished vaginal and clitoral blood flow, especially those who have atherosclerosis. Atherosclerosis is where your cholesterol is high and your blood vessels are plugged with that yellowish plug that is a lot of lipids, okay? And so this may result, if your blood is not flowing in your reproductive organs, dryness and pain during sex, okay? Yeah. Neurogenic is where now we're talking about the nerves, and those who have had, for example, spinal cord injury can also manifest that way, because you have to imagine all the nerves going to your reproductive organs originate from the spinal cord at the level of your your sensations with a condition that generally affects
Doc, we've lost you completely.
Okay. So neurogenic, I was talking about spinal cord injuries and just basically any conditions that may affect the functioning of your nerves, okay? Good. When we're talking about, let me do my slide share from current slide. There we go. Hormonal is any disorder that affects that axis, and that axis is called the hypothalamic pituitary axis. Basically, as I said, all your hormones are made in your brain. All your hormones are made in your brain. The master gland is usually the hypothalamus and the pituitary. So anything that disrupts the movement of these hormones from your brain to your ovaries to finally the recipients of these hormones will definitely affect sensation, okay? So we have what we call medical castration. As I said before, if I was to do a surgery on you, remove your uterus, and I end up removing your ovaries. If an ovarian cyst on you, and I end up deciding, you know what, this ovary needs to come out. What I've just done is removed all your hormone producing organs, and basically I have sent you into immediate surgical menopause, okay? Premature ovarian failure refers to women who are not of a perimenopause age, so they've not gotten to around 40 years, but they have their ovarian reserve or their hormones switching off. So you can actually find a 25-year-old totally behaving, looking, and even the hormones reading like she's in menopause. And it's an actual diagnosis. It's called premature ovarian failure or premature ovarian insufficiency. Wanaotumia family planning, anything that is hormonal, my friend. If you're taking in pills, if you're taking in the injection, what we call the Depo-Provera, and if you're taking in the implant, those are things that we have to consider. You may have vaginal dryness and low libido and all these things simply because you are on that thing. How they work is they go to your in endogenous, what is it called, production of your hormones, and they try and suppress. So I'm giving you estrogen outside, progesterone outside, so that it can go inside and tell the inside, hey, tumekuja kutoka nje. So now you, who is from inside, kindly reduce your function so you don't ovulate, so that you don't get pregnant. But you see, when the inside reduces its function, what happens? All the other organs also sort of suffer. So even libido suffers because we're depending on these same hormones that we're trying to suppress, okay? Good. And of course, we have a patient presenting with decreased desire, dryness, lack of sexual arousal. Musculogenic, as I talked, is usually either the muscles are hypertonic, they contract, they tense up, or they are hypotonic, as in found in sagging muscles down there with chronic childbirth, or vaginal hypoanesthesia. The muscles are there, but the nerves to the muscles are sort of under, okay, performing. Psychogenic, emotional and relationship issues. Oh, my friend, this stems from self-esteem. You're looking in the mirror and you're not liking what you are seeing, and you're not relating the image you're seeing as a sexual being. How you present and how you offer yourself as a sexual being matters a lot on how you see yourself. Body image, you're looking at the mirror and you're looking at this person with say, for example, obesity. If not obesity, there are those who are excessively thin. They're just not okay with how their body looks like, okay? I usually say the esteem plays a role into your confidence, and that plays a role in your psychology, and psychology plays a role into your mind, and the mind is the beginning and is the biggest sexual organ that a woman has, okay? And the quality of a relationship with a partner. And here is where I'll take a pause and I say, I'm glad in my audience I have men and I have women. I will now address the men. Hii tabia ya, you're just about kuanza kucheza mchezo, and you just slip a finger down there just to touch. Is she wet? Is she ready for me to penetrate? And you find a little wetness and you say, she's ready. and you're tweaking the nipples as if they are, volume knobs. No, my friend. There is a role of foreplay. There is a role of communication. There is a role of communication, meaning expressly, back and forth. Each communicates very clearly what is working for them, what is not working for them. And here's the truth. And this is what most women may not say, and I shall speak for the women and the men who are in here. Things do change, okay? The girl you married when she was younger, if the volume buttons, what I'm calling the nipples, you tweaking them was working for her, maybe after breastfeeding, they're no longer working. Please stop it. Ask expressly what is working for you now. A woman will tell you, touch here with this frequency, with this speed, like this. What works for you, so that we stop here pretending that there's foreplay and there's actually no foreplay, okay? Quality of relationship also goes to communication about other things. It is very unlikely that I would have emotional issues with you and, other issues, financial issues, and we're not communicating, and on the bed I'm dripping wet. How? Dry as a cassava, my friend. Medications. So these are medications that will actually inhibit the metabolism or reduce the metabolism of your hormones, okay? Good. I hope we are together. Are we together? I see you're all laughing in the chat box, but I hope you're getting something. Okay, how then do you approach this patient? What is the clinical evaluation looking like? So you're looking at the medical, physiological evaluation. You're also looking at the psychosocial. You're looking at the psychosexual assessment, okay? And how does that look like? That looks like taking a full history. Actually, there's a lot of talking. If you came to my consultation room, you'd find that I do not have a typical doctor on this other side, and then a table, and then a other side. In my personal hospital, my friend, it's couches, and then there's tissue hapo katikati. And there's a reason there's that tissue. When you actually do take time to talk, you'll realize most of the time you've treated the woman even before you've written anything. Okay, so full history, physical exam, and a pelvic exam. And these are skills that are lost to us if at all there are any medics in the house. We are no longer examining, we're no longer touching. We're just depending on what the literature says and the tests, what they will say. Kindly do a hormonal profile. You may have a woman who's gone into premature menopause, and here you are trying to give things to revive the system. So you're looking at the prolactin levels, testosterone levels, LH, FSH, sex binding, globulin, estradiol, okay? You're evaluating the sexual response. You can actually do a duplex Doppler ultrasound of a genital area. Excite her, and then test. Does the blood flow? It will actually measure. What is a vaginal pH? Sometimes when you do tests like a high vaginal swab, it will tell you there's altered flora in there. What is the vaginal compliance and elasticity? And this can come with patients who have had vaginal surgeries or even episiotomy, a woman who has delivered and had a tear and was repaired. I think, Emmanuel, I'll keep touching base if you can hear me so that I'm not just talking alone. Can you hear me, leader?
Yes. You're good.
Perfect. So what happens when there are tears or there are surgeries down there? People heal with scars. It's like the way you can have a keloid, okay? In your ear, you prick, and some women heal properly, and some women form a keloid. A keloid is that big thing that forms. And so down there, you can heal with scars, and scars do not have stretchability. Scars are actually painful. So actually, very many women who have a vaginal delivery and have had an episiotomy and a repair, what they do is eventually when sex starts to happen, they may not say it. They will take the shame of feeling the pain, but actually penetration is painful. So you actually have to assess that. Is that vagina as elastic? Fun fact, what is the definition of a vagina? It's an expandable muscular tube. It is not an open space. It is a potential space, meaning at any one point it is closed. It only opens when it is letting things out or letting things in. And so that means if that ability to open and stretch is lost, then we have pain because now the stretchability is lost. Okay, good. Psychosocial, psychosexual address emotional and relationship issues. And that is why here I will stop and say the assessment and treatment of these women. And did I say female sexual dysfunction affects 50% of women? 1 out of every 2 women will not tell you, but there's something wrong in the bedroom. And I like that you're all here. 1 out of 2 women, there's something going on in the bedroom. Hana desire, hana nini, sijui, uchungu, halafu, compared to around 25 to 31% of men with erectile dysfunction. Fact number 2, dhambi za mwanamke zinafichika. You see, mwanamke, she is to be penetrated, so you will not see her erectile dysfunction. You will not see her organs refusing to function. You will just see a woman silently under you. She may not say it, but if there's something she's feeling that is not right, a diagnosis already should be made. Okay, so you should address all these issues. A subjective assessment of sexual function. And subjective here as opposed to objective, meaning we are not all the same. My expectations are not the same as the other woman next to me. So you're kindly doing an index of sexual function. This is a tool we usually use. An inventory of female sexual function. This is also another tool that we use, meaning expectations are very different. So can we first define your expectations, and then now we start working towards what your goal is, okay? And what is a clinical approach to this woman? You're doing a complete evaluation and diagnosis, and you're looking at the concerns that she has brought to you, okay? You're assessing the goals, as I said, you're counseling the patient. So this is management. You're addressing partner issues, and you're calling in a psychologist. It's a multidisciplinary approach, totally multidisciplinary. She's looking in the mirror and she's saying, Dr. Swabra, I don't feel sexy because number 1, 2, 3, you're probably talking about psychotherapy here. We're talking about body imaging here. We're talking about just basically talking to the woman. You may have to refer her to a trainer. You may have to, everybody here is involved. Hata pasta saa zingine tunaweza ita, okay? Treat associated conditions. If at all she has candidiasis, treat. Vaginosis, treat, okay? If she has scarring down there, if you can repair that, treat, okay? A multidisciplinary approach, as I said, counseling, couples therapy, and sex therapy. And sex therapy is not what we have in TikTok, my friends. Sex therapy is an actual profession here, and people are trained to talk about mindful therapy, to talk about sensate focus. These things are where we gradually introduce things. You can get someone who has the PTSD of sexual trauma and desensitize and bring her back to normal, to functioning as a sexual being. So there is an actual process to it. Psychotherapy, psychopharmacology. And here is now where we can bring in the meds. What meds are we bringing? We're bringing in the hormones. I will not enter the details of, because my audience is not going to prescribe the hormones. But here we're basically talking about 3 things, please. It's not just estrogen I want to put back. Actually, what they don't tell you about perimenopause and menopause, libido, it's not estrogen, my friend. The appearance of those areas down there, it's not estrogen. Testosterone. I know, it's a silent golden bullet. The woman you will give testosterone will come and praise you. Atakuletea mbuzi, Dr. Swabra, sante. You have opened up the floodgates of heaven, okay? Lifestyle modification, and here is where I say, as a woman, I will teach you how to delegate, because you cannot have an exhausted woman. She wakes up in the morning, ameanza, watoto, prepared for school, hapo, mzee akaruka juu, morning glory, haya, akachambuliwa, siku ikaanza, apike, afanye, asafishe, haya, she's a career woman, goes to work, gets shouted by the boss, sijui, traffic jam in the evening, comes back, has to cook. By the time she's settling down and taking her final shower, it's around 11 p.m. She's exhausted, and then she still has to perform. People, delegate. Practice mindful resting. Practice mindful resting when you're sleeping. Like, actually do sleep, get your hours in, and then of course the role of exercise cannot be overemphasized. Chakula. You know me, I will always go back here. Let food be thy medicine. As a woman, what are you reaching out for? You're talking about libido. Nakuna wala nini? Tafadhali take chocolate, and we're talking about chocolate. It's not easy zetu, okay, commercialized. We're talking about high cocoa levels. We're talking about dark chocolate. We're talking about unsweetened chocolate. Okay, we're talking about ginkgo. We're talking about Asian ginseng. We're talking about berries. Okay, think cranberries, think blueberries, think strawberries, all that. Oysters, oh my friend, oysters. Okay, whether you will take them raw, whether you will take them cooked, doesn't matter. Pomegranate, okay, is another one. Watermelons, okay. Apples. Apple has an extract. It's called pectin, and the role of pectin in forming polysaccharides, which is now the precursor for these hormones that are going to be produced, is undermined, okay. Avocados, which give you the healthy fats so that you form good fats. Oily fish, you're thinking calamari, you're thinking salmon, you're thinking all these bougie fishes, okay. Sesame or tilapia na ubambla. Na sijasema hizo ni mbaya. You're talking about maca, you're talking about saffron, tribulus honey, you're talking about nuts, and here we're talking about walnuts, we're talking about cashews, and then of course red wine, and here I will say that with a pinch of salt for the sake of the religious people in the crowd, okay? And so then, if I've talked about food, I will also talk about supplements, because supplements are just food compressed into a tablet, isn't it? Okay. And if I'm talking about the supplements, Aki, if there's anything to screenshot here, it will be the supplement bits, okay? And so I cannot start this conversation without starting with, I call this the mother of all supplements, and give this supplement from a girl who's in her period from around 14, 13 years all the way to a woman in her postmenopause. There is literally no woman who doesn't need Vitalize, okay? So it has isoflavones, it has donquai root extracts, it has black cohosh, it has folate, it has all that. But what exactly am I looking for in Vitalize? Two things. It has two things, okay? It has what we call chisandra berry, and then it has, okay, I've forgotten the name of the other one, and the way I usually, passion flower. And this I will speak about, especially in the context of a woman in her menopause. Chisandra berry and passion flower are neuromodulators. So you saw me talking about Sijui hot flashes, about a woman who's not sleeping, about a woman who's overfiring her neurons. You know, she's just not settled, okay? Her autostat in temperature regulation is not settled. Chisandra berry does that. It does that for you. It calms it for you. Actually, I would say Chisandra berry on one hand, meditation on the other hand. It's equivalent. It calms down your neural system. It calms down hyperactivity of your hormones over other hormones. It elevates the function of estrogen, the little that is left, okay? It also has folate. You need folate as a woman, okay? You're making all these blood cells, you're making all this, you need folate. It has vitamin D3, B6, vitamin E, all these things that are good for your skincare, all these things that are good for your precursors for hormones, all these things that are good for your bones. We talked about vitamin D and calcium, okay? So this supplement for a woman going through the thick of it sexually cannot be overemphasized. It has iron, it has calcium as well. I will tell you a story about royal jelly. And I love royal jelly. It is the most abused supplement in my house. When in a bee colony, usually in a beehive, there is one bee that is in the middle of it all. She's called the queen bee, and she's untouchable. She's royal, okay? She's the biggest. Her only job is one and one alone. Everybody serves her, everybody feeds her, everybody attends to her because kazi yake is just to lay eggs. Now, when a beehive goes through a crisis, the queen bee dies, they don't panic. Imagine they don't, okay? And they don't have to go selecting at a special whatever worker bee who will, they go to the larvae, the little bees that are just being born. And they are all the same. And what they do is, and I like this a lot because it also applies to life in general. These tiny little larvae are fed what we call royal jelly. It's a protein, it's a food substance that is produced from the salivary glands of the bees. They literally produce it in their mouth, spit it out, and feed it to the young ones. And one, two, or several will show themselves bigger, better when their uptake of royal jelly is that good. And that is going to be selected as a queen bee. So a queen bee is not, beaten into the role, is not taught the role. A queen bee is made. So just away from this discussion, your circumstances don't define you. You define your circumstances. Just feed yourself royal jelly in whatever circumstance, okay? Even in your mind. You just decide, I will change my environmental circumstance, I will put in the right information in my head, and I will change my circumstances. That is the power of royal jelly. Now imagine the power of royal jelly to a woman going through her menopause. Okay, we are having all these precursors to all these beautiful, beautiful hormones. Royal jelly in fertility, royal jelly in menopause, royal jelly in libido cannot be overemphasized, okay? And then we have what we call multi-marker. I don't have to talk about marker. The minute you put in your Google marker, it is a sex hub of the incas. Like if you're talking libido, it's marker, okay? Marker. And this is for both men and women, okay? And this, our marker, the Forever marker, features an exclusive blend of marker and other natural ingredients, okay? So for example, it has enzymes back, and these are usually supposed to encourage a relaxed, positive mood, okay? Settle your mind, okay? It has what we call L-arginine. Aki, you people, I'm big on L-arginine. It is nitrous oxide precursor. Every time you hear nitric oxide or nitric oxide, you're hearing vasodilation. blood vessels enlarging. Kama ni erection, tunapata erection ya kishua. Kama ni vasodilation uko chini, we're getting engorged with blood. That is what we're wanting. That is what we're looking for. When we're looking for lubrication, you want to be vaso-engorged, okay? So it includes maca, muira pama. Muira pama is another herb that is found also still Brazil countries, Peru, and this is also a sex herb and a fertility herb. And also it has Tribulus terrestris, my friend. Now, we have aloe berry nectar, and this is a beautiful, beautiful product in the sense that it contains 90% aloe vera gel. What does aloe vera do? It cleanses. It cleanses your system, prepares your system for utmost absorption. You're here, you're looking to take all these supplements so that they can serve you and they can feed into your libido. But your system is so clogged up with toxins, you're not even absorbing. Okay, so it has aloe vera that cleanses your skin, cleanses your gut, improves absorption of hormones, improves absorption and metabolism of hormones and all those things. It has vitamin C, and vitamin C we know is an antioxidant. It has apple juice. Remember I talked about apple juice? Apple juice, every time you hear apple juice, think pectin. Pectin contains polysaccharides, precursors for all these many things. It has cranberry. What does cranberry do? It is a urine alkalizer. Hautashinda UTI na hapa. And UTI and sex, very, very painful. So cranberry here, urine alkalizer, urinary health, hormonal health, okay? And it settles everything down beautifully. This is a go-to, and it tastes so, so delicious. And then we have Actic Sea, and I usually joke, anybody, as long as you're 6 months, a child was 6 months, up to the day you die, you cannot convince me you don't need Actic Sea. Everybody needs Actic Sea. What does Actic Sea do? We are now going to the arteries that were clogging up. We're removing all those lipids, okay, the cholesterol, the atherosclerosis, okay? This contains DHA, it contains EPA, it contains fish oil omega, it contains alpha tocopherols, all the beautiful things. This also sets your mental state. For a woman who's going through the thick of it in menopause, perimenopause, it calms down your mentality. It calms down your hyperactive brain. It prevents and protects against dementia. So we're working on the blood vessels in your body. We're working on the blood vessels in your brain. We're working on the blood vessels in your genitals. We're working on all blood vessels. Everybody needs Actic Sea. Aji. My God, I love this product. Emmanuel, I love this product. Have you heard me? Emmanuel, I love this product. You know what I mean. Agi is L-arginine, and L-arginine contains nitric oxide. And nitric oxide, we know, nitric oxide is a vasodilator. Every time we're talking about sexual dysfunctions, we have to go back to the basics. Where's the blood flowing? Okay, where are we lubricated? It has L-arginine, it has pomegranate. Remember, we saw pomegranate in the foods we should eat. It also has grape extract, which falls under the category of berries as well. Okay, good. Thank you so much for your time. I welcome now any questions that I may have missed in the chat or any additions. Emmanuel, are we together?
Yes, you can chat. I don't know if can you access the chat box?
I can, but I now would have to scroll slowly. What would you recommend for recurrent yeast infections? I would go back to testing. A high vaginal swab would be very important so that we see, we're not assuming it is just yeast, it could be an underlying thing. So a high vaginal swab as a test. And then now in terms of medication, our garlic and thyme is so beautiful for recurrent yeast infections. And then of course, lifestyle modifications in the sense that, you know, cotton panties, you know, aeration down there. You're not exactly clogging the aeration and, you know, breathing space down there. You're not douching. You are not, you know, doing all those things. Waswahili wanasema kufukiza uko chini. People actually put perfume down there as if a vagina is supposed to smell a certain perfumey smell. So usually just basically keep it clean, keep it healthy, and take your probiotics. So of course, I will always go back to, other than the garlic and thyme, let's go back to our Pro B. Okay, Pro B is very good, has lactobacilli, which now reinforces your natural defenses against outside infections. Okay. I see volume knobs. People were laughing a lot. I'll have to scroll one by one. Unasindikizwa clinic ya 6 weeks. Cassavas or just chilling. Okay. Hello, after the talk, it's in order to send the whole study notes in the group all kindly. Thumbs high for this super class. Does vaginal pH determine the sex of a baby? No, no. It's a sperm of a man that determines the gender of a baby. I have a client who has 3 girls and her gyna says, wewe nione kando. Hii haiko hapa kwa sexual dysfunction. Reduced sexual urge during pregnancy. It boils down to, number one, body image. It boils down to the hormones that are flowing through you. It boils down to a lot happening. Your body anatomy has changed. And fun fact, pregnant women have more vaginal infections. So it always goes down to that. And then, of course, now the woman, you have to imagine her pelvic floor is carrying a weight above it that is like potentially 7 kilograms and above. So I usually say it may not necessarily be the painful sex, it may not necessarily be how has reduced libido, it may actually be just a position thing. So please kuja for consultation so that I can tell you the positions you assume as a pregnant woman. You're probably not looking to have penetration from behind or a man above you. Probably the woman should get on top. Kuna cha kifo cha mende hapo. No sexual urge after betrayal, infidelity. We have touched on communication and psychotherapy and all those things. So of course, if there's no trust, there's no communication. And that means just by the workings of it, sex is a very, very neuropathic process. And so if your mind is not ready, your psychology is not ready, your genitals will not be ready. Everybody wants the notes. Talk about menses delay after delivery. How long should it take? Yes, a woman was delivered, others will get a period even 1 month after delivery. I call them the unlucky few because surely how unlucky can you be? There are those who, as long as they're breastfeeding, even 2 years down the line, they still haven't gotten a period. But here's a take home. The lack of a period is not lack of ovulation. Usione huna period, ukaona huwezi pata mimba, ole wako. So we should always talk family planning. Again, can you get pregnant before the menses are back? Absolutely. Akachambuliwa, okay. Can a woman lose her ability to lubricate after C-section birth? It goes back to surgeries. It goes back to how you've healed. It goes back to how you perceive your body. So here we're talking about a lubrication issue. So that means we're talking about an arousal issue. So, and there's also no shame, by the way, for using lubrication, okay, as you ease back into it. And you also have to imagine after CS, what is a woman doing? She's breastfeeding. What is up? Prolactin. So that means her libido is going to be down. So it's not so much the CS, it's probably the prolactin we're talking about. Notion of a superwoman should be scrapped. Absolutely. I do not like super women. I like all-rounded women. Men should just love and be kind to their women. I absolutely agree. Men should actually concentrate on foreplay instead of judging women. How I love this session. Thank you very much. Daktari Asante in advance. Thank you very much. She uses family planning for a long time. After stopping, she's trying to get pregnant with no success. Yes, family planning can suppress, not stop, suppress temporarily, meaning they delay fertility. They do not banish fertility, okay? So there's that delay. And if I could summarize, when you're talking about the pills, we're talking about 3 to 6 months. When you're talking about the injections, 9 months to 3 years. And we're talking about the implant between 6 and 9 months. So you also have to give that room for waiting. Okay, can you take them when you're pregnant? Most of these supplements are actually safe in pregnancy because they're herbs, they're roots, they're food. Okay, but of course, consult the person who's giving them to you. They know better. What would you recommend for recurrent yeast infections? I think I've answered that. How can I boost my libido? Actually, after this whole presentation, Muna, nione kando sasa. How to effectively treat PID, which is recurrent. PID is a bacterial infection. It needs to be examined, it needs to be tested by lab, and it needs to be treated, and there's a specific protocol for it, and you treat the partner. Otherwise, you're just passing it back and forth like a relay. What will you recommend for endometriosis? Oh, no. This is a big topic. Endometriosis has medical proper management. Endometriosis has proper surgical management. It doesn't fit in here. How do I get rid of PCOS? You do not get rid of PCOS, you manage PCOS. Ladies, make sure you do your annual pap smear. I agree. Mammograms is for those above 40 and ultrasounds for those below 40. I like that though. Low libido all through the cycle. You probably have hypoactive sexual disorder, as we've talked about. There are ways to go around it. Okay. Emmanuel, have I covered everything?
I think you have done more than enough. Um,
Okay, sawa sawa.
we can leave it there. It is a
Okay.
serious topic of interest, and definitely we need to stop at some